And we'll begin at the back of the room who had the...
You know, one of the questions there around centralized and federated, one of the questions I'd love to get your opinion on is, are there really good examples of federated systems that have worked at scale, particularly in the biomedical space, outside of library systems where, you know, it's like lightweight data?
There we go. So the best ultra-large scale system that is out there and works at scale is something called the internet. It's highly decentralized. There are some things that are based around standards in terms of its kind of portfolio of activities. There was a report that was done in 2006. If you do a search on ULS space SEI, so it's Ultra Large Scale Systems Software Engineering Institute, you'll come up with a report. Read the first 28 pages. It's a pretty easy read. But it describes the problem of trying to create these complex systems. And it answers the question, or it tries to answer the question, what do you do when you have a billion lines of code that all has to interact and work together? And I think the fundamentals that they talk about there is that centralization at some point falls apart. So you have to think about how this might be federated. But I think the internet is probably the best example of a large system at scale that is federated and works.
Lucilla?
Right. I would add that there are two major initiatives going on right now related to federation of electronic health records or electronic health records data, one from PCORNet and another one from the CTSA consortium. So we are looking, and this did not come from, they're not being experimented only now. They came from previous results that some institutions have done this before. So I think, you know, that we're going in the right direction here.
Hey, Mark Williams was next.
Well, if I could just add to that, you know, and I think not only is there the technical specification, but I think there's the social issues involved, the social and business issues involved that, in my mind, make a federation attractive. So you don't have this problem of a system collapsing under its own weight, and you have active engagement of a lot of really smart people, and you have the ability to produce business rules, I think, that make everybody much more comfortable with doing business under that mechanism.
Okay.
Mark Williams, Geisinger. One quick comment. There's another consortium, and I know, Lucilla, you didn't mean to be comprehensive, but the HMO Research Network is actually has a common data model, which PCORNet, you know, has essentially leveraged for its efforts. The question I have, I think, is to Doug. Both Doug and Josh mentioned triangulation for truth, which I think is really important, and I think there's an opportunity here to tie into some of the engagement activities that we've talked about earlier. Triangulation to this point has taken place in the context of the healthcare system, where we look at records and we look at different sets. But with very few exceptions, we really haven't engaged our patients or our participants or partners in these efforts of triangulation around truth. Our Open Notes project that we've done has been very interesting in that regard by exposing the entire electronic health record and allowing patients to communicate about what they see as truth as opposed to what we've documented as truth. And so I think it would be something to potentially consider in this engagement model to say, what is the role of having a patient perspective on definition of truth around phenotyping, and how would that impact discovery? So I'd be interested in comments.
I would just make one comment. So in our electronic health records linked biobank, we also collect a survey instrument, which includes self-reported family histories and self-reported diseases and medications. And so it's been very instructive to compare what the participants think their medications and diseases are with what the electronic health record thinks their diseases and medication are. And the really instructive piece of it is neither one is always right.
I would just add to that that could help eliminate some errors, but it wouldn't result in true truth, similarly just because of all the diagnoses we consider, and that maybe even for years before then finally getting that piece of information that includes or excludes that diagnosis.
And I think the engagement piece is key to literally make them feel engaged, but as Josh has probably experienced, each additional data source you add on top, its incremental value is decreasing. You're asymptotically getting towards the truth. And so we need to be, the choosing wisely concept is very applicable here. We need to pick enough data sources that we get to the 90% plus. And then we can obsess about these other data sources, but the reality is they're not as valuable as the first 4 or 5 you went after in these first 4 or 5. And maybe patient engagement actually helps and is one of the few that's worth going after, but there's 10 other data sources to go after. Those last 10 probably won't help incrementally that much more.
Okay, so this is your Q check, Sakar, and then Philborn, Rick, and we'll add Mike to that. All right, so Sakar.
Yes, Sakat Rayson, Mass General Hospital. So I want to congratulate the eMERGE group on the wonderful work in thinking through how to use EHRs productively for science. And so, but if we enroll, let's say, 1 million people in this cohort, and where the EHR is going to be the key phenotyping tool, there may be hundreds of EHRs, let's say 100. The key question is, how do you reduce the heterogeneity given the lack of interoperability between the EHRs? And we've seen a couple of models on how to reduce heterogeneity. One is embedded recruitment within a nation that has an EHR like UK or a system like the VA. I'm just curious to the panel as to how to reduce the heterogeneity.
I think one of the lessons that we've learned, across eMERGE, we have that same heterogeneity. We have multiple different electronic health records. We have commercial health records, we have homegrown electronic health records, and I think one of the things that has been very instructive is how it's possible to extract from each of those, harmonize, and make a story that makes sense. So I guess I'm not too worried about that problem. I think we can solve it. It may be a little more difficult if we go from a handful to 100, but even 100 is probably the upper limit. There's probably not that many more. So I think that is actually a solvable problem.
Yeah, and I would say there are several examples in which that has been done. The other myth that we need to dissipate is that if you have the same vendor, you have data harmonized already.
I think there are elements, two caveats. One, you can get common data models, which helps with some of this aspect. And to some degree, I think eMERGE is doing that, even though we haven't actually set up a specification for it. We all know what kinds of data we need to get out routinely. But the other thing that's interesting is within eMERGE, it does exist as a federated model, but it's not automated at each site. It is something that there's a group of experts that are used to the data and can mine it efficiently. And so that's the hurdle that sort of would need to be bridged as we federate across many different EHRs.
So,
I'm sorry.
So I'm going to be the naysayer with this, because there are 1,800 certified products, at least for meaningful use stage 1, and it's not scalable. And if we try to create a consistent common data model, for example. There's a reason why the transactional systems use HL7 as a standard, and then they can't ask easy questions, and they extract it into a clinical data warehouse, because they have a different common data model, if you will, about how they organize the information, which is, again, different than how clinical research is done, because their common data model has interventions and arms and controls and things like that. So I don't think we will ever have a single common data model to rule them all, okay? So we have to understand that that's going to be the case. And so what is the common denominator with all these things? I actually think it probably has to do with granular data, so that eMERGE can create their common data model using common data elements that then can be transformed if you want to extract it from the electronic health record, or if you want to use it in say, a clinical study. I think if we focus on common data models, which are really sort of how you structure that information, we're going to get ourselves down an ontologic rat hole that isn't going to get us to where we want to go. We have to think much more simply about how to get that data out.
I think the heterogeneity problem is a bit overstated. I think those of us who, Josh has been doing this, eMERGE is showing it. The place where it becomes particularly important is as we try and step outside the university of blanks. So as we think about how much within institution effort it takes to get it into either into a data model or into a similar structure, If we truly want to get a representative population, not just in terms of diversity of race or ethnicity, but diversity of environmental factors, practice patterns, care patterns, what we were discussing earlier, you have to get to those non-university settings. And that's where you have to partner with the vendors to say, we're not going to have a Josh Denny sitting at every hospital in the United States. We're lucky we have him at one. Well, we have to figure out, what do we exclude those patients and exclude, more importantly, those care processes? These genes may matter on outcome if you're having your outpatient care delivered this way, but if you have different care, maybe they don't matter. So it's not just about the patients, it's the care processes. In order to make that happen, I think the heterogeneity has to be established to say, we're going to get out what's easy, which is actually a disproportionately large proportion of what's useful. And the part that varies from vendor to vendor, there are ways to get people to map it if you give the vendor a specific point to go to, and if you give the vendors a scorecard. That's what we've done in our collaborative, which is the vendors see how many patients they've enrolled as part of their implementation. So they get credit for doing it, not just as certification, which is 1,800 certified products, none of whom talk to each other, even though they're all certified for interoperability. But how many of those are actually on?
Okay, they're not certified to interoperability. That's the first question.
So achievement isn't certification. That's the beginning. It actually is up on this website. How many of these have come from Cerner? How many of these have come from Epic? How many of these come from homegrown? And that's the culture they live in. They need to show value to their shareholders and to their priority setters.
Okay, Phil Bourne, you were next.
I want to address the sort of issue of ownerships. So, I mean, I'm thinking about, I would agree definitely to the notion of a federated system. If you take Doug's example of the internet itself, I think in many ways it works because everybody feels they own it and no one feels they own it. And I'm wondering in, say, eMERGE or in these other systems, how the notion of ownership, whether there's anything particular is done to give the sense that the community at large or the participants or the providers feel like they own the complete system, because to me that seems like a very important point going forward.
I run a perioperative medicine group. We've got about 30 hospitals now, many of them University of Blanks, and they've historically felt like they own their data. And the only way we were able to get these very well-known organizations to share their data was to continue the concept of ownership, that they own it. We are simply doing the code check model. So our data use agreement says there is a centralized entity because it's technically easier right now, not because it's necessarily the right thing, but it's technically easier to run analyses on the entire data set at one place. The exact same data for that organization is sitting at their place. If they decide they want to pull out of the consortium, we write one SQL statement, it deletes their data, and it forces the consortium to actually have the right incentive structure. So we don't do bad things centrally because we have that constant threat of people leaving with the data they own. But it's a code check model. We're holding it for them, but it's still theirs. And that's worked very well to allay these trust issues, yet create a centralized structure.
And that's more or less how the eMERGE system works as well. I would say, though, it was an interesting process. We fairly early on in eMERGE had to create the data use agreements that Josh referred to in his talk. And it was an interesting process. So we started with a data use agreement, actually, that we got a lot of advice from the NHGRI on. And then we went to the first site, and they added a bunch of stuff. And then we went to the second site, and they added a bunch more stuff. And we never even made it to the third site. What we decided was we needed to do it differently. So we went back, and we started with the clean document. And what the stuff that people were always the lawyers were adding was restatement of federal or state or local law. And so we just simply added a statement that said, we will agree to abide by all state, federal, and local laws. And then we had a phone call where we met with the PI at the site, plus the person that was the decider on whether or not they would sign on this, and had a conversation about what the goals were and what the outcomes were. And the amazing thing is, with that approach, we were able to get a 2-page data use agreement that had almost no changes to it across 5 sites. And then when we brought 4 more sites into the eMERGE network, they basically just all signed it.
Yeah, I would like to make a comment that it is not easy to get these organizations to share access to the data, but the federated model helps a lot in that way. I think in terms of precision medicine and data ownership, we need to revisit whether the institutions own the data or the patient owns the data, because the voluntary participation in a lot of studies could be facilitated if we allow this to happen. But making it happen is what is probably the roadblock right now.
Can I just be the advocate for the patient here? We're talking a lot about researchers and organizations and institutions and how we can kind of make all that work. The whole point, if we're going to change the way we do this, is to empower patients. And if patients have a copy of their data, they can post it on Facebook if they want. Now, we wouldn't recommend that. But I mean, at the end of the day, if we can empower patients to be much more participatory in this, it actually turns the whole thing on its head, so that institutions are the ones that need to get the data from the patient rather than the other way around.
Okay, so we're going to do a Q check again. So we have Rick Nosson, then Rick Lifton, Mike Gaziano, a question coming from the web, and then John White, Kevin Patrick, and David Goldstein, and Terry Manolio. All right, so Rick the first.
Yeah. So Rick Knosson, Intel. On the question of federated versus centralized, it seems like the working group is recommending federated, which I think is right, particularly when you're trying to get cohorts of existing data that the organizations don't really want to let that data go. And if we talk about the person owning the data, we're in a similar situation. Then I think we get to the very next question, which is there's some pretty big data sets out there. So any thoughts about whether there's some good capabilities to package up programs securely and send it to the data and get the results back versus having the data transferred to where the programs are executing?
Certainly. So within eMERGE, we have been exploring different computable options to send to the sites against more common data models than less. And that's been pretty effective at transporting. And we've looked at a couple different technologies. I think we're fairly technology agnostic, but the idea is to keep that logic, which implementation of the logic can be fairly complicated and is potential for error. So if you can encapsulate that, that makes it much more efficient. The other thing to say about in terms of centralized versus federated is, in eMERGE, we actually have a little bit of both. So the complex algorithms are federated, but we've built a tool that anyone within eMERGE can go to and query the data and get real-time counts as they look at simple things like billing codes, medications, and get an idea whether their phenotype that they're interested in is even of potential interest. If they see 3 cases, it's probably not worth doing. And that hypothesis exploration tool is pretty it runs on a centralized model, and we can control the data model for that. Whereas if you try to do it federated, you might have problems given the diversity of connectivity and data models, et cetera.
I would just say that I think it might be premature to say that we're recommending a federated model, but I think we should have that discussion in a robust way.
Yeah.
Lucilla.
Well, and I would say we started very simply counting things around, rates and so on, but we, as a community, have developed distributed algorithms. So even multivariate analysis you can do without transferring the participant data around. You can decompose the algorithm and then get intermediary results, some covariance matrices and so on. And you get the same result as if you had all the data in a central location. And this has been very powerful in terms of the, again, the institutions keeping the data locally. And I think even internationally, because as you know, there are some international laws about not physically storing data from some countries outside a certain area.
Rick Lifton.
Thank you. The eMERGE consortium raises a different model than what we've heard about up to now, namely a consortium of tertiary medical centers. And these have some advantages in seeing typically more severe disease and rarer diseases than we would see in other ascertainment schemes, and also some disadvantages in not capturing all of the care of an individual patient and maybe having less traction on longitudinal follow-up. So I'm interested in your thoughts about the strengths and weaknesses of this kind of a contribution to a cohort.
I think that's a really important point. If you're looking carefully at our slide on the validation of hypothyroidism, performance was less at one site, and that was, all the others were easily above 90%. And the difference at that site was they had a lot more patients where they kind of flew in for subspecialty care and then flew out. And so they did not have as longitudinal and as comprehensive a record for a primary care illness like hypothyroidism. And so I think that becomes an important aspect. There are ways you can look at the record to ascertain that these people look like they're getting primary care at a given site. And then ideally, you would be able to pull data in across regional health providers in a health exchange type format, or have the patient themselves be able to share the information, as Doug discussed.
If I could just make a quick clarification. It's not all academic medical centers. There are two large healthcare delivery systems that are part of eMERGE, Geisinger, Marshfield, Essentia, where we do have the longitudinal data. And what we found is we can actually work together very effectively.
So can I just say, we've talked about the HMO network, eMERGE, PCOR, NCATS, and I think Mini Sentinel in the course of the last 2 days. I don't think that this national cohort is any one of those things supersized. I think we have to think about how all of them can be contributing to this initiative, but we have to learn what worked and what didn't in each of those networks, and we may have to come up with a new way of figuring out how all those pieces fit together. But again, it's city planning, it's not architecture. We have to think about what that looks like.
And I wouldn't underestimate the capability of the private hospitals to participate in these activities. We've had payers that have helped out with this. So in the state of Michigan, we've got Blue Cross Blue Shield, which pays for quality improvement work. We've got 72 hospitals, including critical access hospitals, where we collect their data. And the secret sauce there has been they get quality improvement data out of it, but the side benefit is we get research data out of it that actually informs real practice. So as we think about this, the biosample is the part that is totally outside their purview, and that may be the secret that we have to figure out. But getting the electronic health record data, if you give them additional forms of value other than just research, is amazingly powerful. If you enable them to be a QCDR and get avoid Medicare penalties, I think we have to jump on top of things that they feel like they have to do, and this is a carrot on top of that of an additional benefit. That's got to be the strategy for getting out of the University of Blank model. They're very engaged and interested if you make it easy for them and their vendor makes it easy for them.
Hey, Mike Gaziano.
So yeah, I know we can't have Josh Denny everywhere, but there is a really nice VA right across the street from.
It's across a bridge.
Actually, there's one close to all of you guys, as a matter of fact. I think we've learned a great deal from the eMERGE experience, and so I have one quick question and then one more complicated one. The quick one is, are you guys integrating with other forms of data like claim data for your bringing that into the data model? And then the second question is about this further discussion on the common data model concept. And is the primary goal to have a harmonization of the phenotypes rather than a unique data model across all the institutions? And to what extent do you allow the individual partners to modify their algorithm to come to the right answer because of the peculiarities of the specific data sets? And I can just give you an example. We've shared a lot of we've gone back and forth. I think your database is wonderful. I think the input elements into the database have been very, very helpful, and we've got, we keep ours in a much more rudimentary structure, but we've been comparing our algorithms with yours, and so for our Alzheimer's algorithm, we feel it's essential to have the type of doctor, which doesn't exist in most of the other ones. But we could get to an Alzheimer's answer, it will be with a different algorithm. And so you talk about testing in one and moving it to another. And in some cases, I think that would work. Like a diabetes definition, you're probably going to have common data elements because the meds are so important and the ICD codes are fundamental. But I wonder if in some cases, the algorithms might need to be tailored.
That's a great point too. I mean, there is that goes on across eMERGE. When you go, and maybe this is a facet that we see across genetic phenotype algorithms as we think about precision medicine versus maybe more traditional cohorts and the need to get deeper into our data, because a lot of these algorithms do want to look at a specific type of doctor, a ophthalmology visit, for instance, was one of them. They want to look at certain types of reports, things that may not have been envisioned by your common data model. And you're always getting deeper into the data, and we're always trying to subdivide or think about a phenotype more carefully. And so there are those local adaptations that happen. Some of the things that we've shared, for instance, is an algorithm to go, an NLP algorithm that goes and parses a report for a given thing. But you have to figure out, where the colonoscopy report is. It'll find the polyps, because how we write and find colonoscopy reports are different at every site. And that's not something standardized really in any standards vocabulary that I know about yet. And so so there are those local adaptations for sure.
Claims data?
Oh, claims data, yes. Some sites do use claims data. Some sites have pharmacy data as well for fill records and things like that. And we've looked at comparisons of pharmacy fill records versus prescribing data, and they actually align pretty well. But it's a little bit harder to use the non-pharmacy filled records, which of course at the VA you have in abundance.
Right, we do. And it's interesting. Back to that question about what's truth. There's often a disconnect, which is why we ask our patients of what they're taking. I have them keep a list every time they come in, what they're taking. I always compare it with what's in the computer. But what's interesting is that the truth depends on the question. If you want to do a pharmacogenomics and you want to ask, is Mr. Smith on metformin, you need to know what he's actually doing. On the other hand, if you want to know, does he have diabetes, whether he takes the med or not is not the critical question. It's, did the doctor prescribe it? And the doctor prescribed it for Mr. Smith thinking he had diabetes. So it all depends on what the question is, on what the right truth is.
The claims data is an interesting piece. The one outcome of this group could be taking the political capital of the NIH and pushing CMS. It was very exciting to see Dr. Collins and Burwell at the same table. It's easier for us to get Blue Cross Blue Shield data from multiple states than it is to get CMS data for anybody. We have to actually have to get patient level data, and people in the room know that. At the VA, you've got access to NDI, because I don't know if it's because you can afford it or because you're getting it, but the rest of us can't get to mortality data anymore because the death master file no longer being useful or valid. And those claims data and other pieces are a real opportunity to say that if you want to get other people to send their data to this thing, we used to have great success with getting people to send data because we used to tell them their patient has died. They didn't know that, but we told them, by the way, that patient died. We don't know what their name is. We would do blinded record linking centrally, and we'd tell you, your patient died. We don't know who it is, but he's dead. We can't do that anymore, and so some of the value propositions are now gone. So I think the claims data Medicare piece cannot be understated when we talk about the cost impact of this proposition.
Okay, we'll move on, and we have a question from cyberspace.
Yes, this one's from Twitter. Physicians use free-form text and don't update the more mineable patient problem list in EHRs. Do we need natural language processing?
I can answer that one, but please.
Yes.
Well, no, I'm just adding you to the queue.
Oh, sorry.
All right, so we answered that one easily. All right, so next, John White.
Hey, John White from ONC. So you all have raised some great points about electronic health records. I'm not going to address them all, but I do just simply want to state for the record that ONC is just super pleased to be part of this initiative, to be partners with NIH and the FDA and everybody else in the federal family, and we are really deeply engaged and want to see this happen on behalf of the American public. On a personal fanboy note, I can't believe I get to work with Francis Collins to make this vision a reality. I mean, how cool is that, right? So just, all great points. I look forward to deeper discussion, but ONC is committed to making this happen. Thanks.
Okay, Kevin Patrick.
Kevin Patrick here. This builds a little bit, I think, on what Doug Friedsma is talking about city planning, because haven't heard a word about mobile data, about the previous panel, and about how we're going to be bringing this in, because, while it's mind-blowing how you've been able to sort of characterize phenotypes, I think we can enrich this phenotypical characterization, as we discussed this morning, 24/7, lots of new data. How are we thinking about joining these forms of data? I mean, have you guys got notions or ideas about this, and how can we bring our worlds together?
to be honest, questions like that are why I think a centralized model actually still has a lot of value. Imagine doing a distributed model from your mobile phone to just your hospital. I think you actually have to do that linking centrally, and that's using things like blinded record linking, things that AHRQ supports, things that NIST has standards on, but IRBs are still uncomfortable with. So if you've got that patient and they give you just their name, their date of birth, and their address, you can get like 98% probability link that to data centrally without you actually sending that data to the central repository. And that linkage is entirely possible if we've got a, whether it's a health kit or a Google Health, if that data can be sitting there hashed in a consistent way, those codes are brought, that linkage is eminently doable, and it's been done before. It's not a technical issue. It's a deciding to do it issue.
So that question is exactly why I think it needs to be decentralized.
Glad to see agreement among the group.
When it comes to mobile, I think you have to figure out what the common denominator is. I think most mobile platforms, for the most part, have size and battery and space considerations. That means they may need to use kind of proprietary ways of storing the information locally, but eventually it gets transferred to a hub someplace, or it gets transferred someplace where it has to integrate with the electronic health record. I think actually having some structure that's relatively parsimonious to help understand granular data that's coming in and coming out is kind of going to be that connection in. And if you think it's hard to connect 1,800 EHRs, think about 300 million patients out there with all their unique devices. I think we have to start thinking about this not as some giant centralized thing, but the HIE of one, the health information exchange of one, in which it is the patient who has the most to gain by making sure that things are integrated, and getting access to their Fitbit, their EHR, being able to have that integrated. We have to start thinking about how we can make that patient one of the central pieces of this, this cohort.
Yeah, I would say I also agree it has to be decentralized for the very same reasons. What we need is some levels of abstractions for things that are useful in the clinic, because a lot of things will not be. And if we ask the same questions of EEGs, EKGs, are we storing all that data? We're not. We're storing the results of it for the most time. So I would think decentralizing is the way to go, but as opposed to other areas, it hasn't evolved to the point that you know what is the minimum information you need to retrieve from that. Actually, sometimes you don't even have the quality yet. So I think it's just going to follow whatever other aspects of data have followed, including the genetic one, which ones are going to be delivered back to the clinician and so on. So there are similarities there too.
Okay, so I'm going to take moderator's prerogative now. We're at the end of the queue. We're not taking new questions, but the last 4 questions will come from David Goldstein, Terry Manolio, Claudia Williams, and Sally Oaken. So don't forget your question, and let's go to David.
If I understood right, a point George Yankopoulos was making yesterday is that effective cleaning and curation of data in EHRs to make the most effective use for research really depends on domain expertise. And this is very consistent with our own experience, where we've sort of learned our way of how to use data in epilepsy. But if I look into other therapeutic areas, I'm kind of out to sea. So I wonder if the experience in eMERGE has given you guys ideas about how one could establish really efficient curation and cleaning approaches, given that it depends very heavily on domain expertise.
It is the holy grail. It's the machine.
It
You
is.
pour the EHR in, and it comes out all possible phenotypes.
So Dan just solved it. There you go. The
A miracle happens.
I don't think it's a mechanical Turk. I think that you do have domain expertise. It's really critical in that involved process. I think we have gotten better over time and a lot much faster with different algorithms. And we know classes of data that get you farther faster. But I don't know a shortcut yet, other than reuse of what's out there.
And I would just add to that. I mean, it's like everything else. We've learned in eMERGE that incrementalism is a good thing. And so actually by doing the cleaning, every next project gets a little bit easier because it builds on that previously cleaned data. So I think, and we heard this, I think, from Mike Gaziano, it doesn't make sense necessarily to clean everything up front. You do it as you need it, and I think that makes it a lot more tractable problem.
Dan, I'm not out of line, but I have to clarify that when Josh presented the rheumatoid arthritis algorithm, that was the first one we did, and it was, it required 4 iterations. And the reason it required 4 iterations is exactly what David Goldstein just said, because after iteration number 2, we finally said, we ought to talk to a rheumatologist. And not because we don't know what rheumatoid arthritis is, but we don't know how it's represented in the EMR. And that was really the epiphany. So domain expertise is really important, but as Josh says, that was 6 or 7 years ago, and we sort of have a handle now on what it is that makes a diagnosis.
Okay, Terry.
I wanted to ask Rex to talk a little bit about the My Research chart, particularly what the uptake has been among patients and what kind of sort of user support you provide to them in interpreting it.
Yeah, it's a great question. So let me break it into 2 pieces. So we have the My Chart piece of this. So we're an Epic installation. So we have the My Chart piece of this, and things like the Promise installation is actually in My Chart, not in My Research chart. So recognize that there is still this research activity that can go on in My Chart. So My Research chart, though, is a place where we wanted, and one of the things that we haven't talked about yet is the problem, and it's relevant to the point I made about us needing to plan on implementation as well. As you're starting to think about putting stuff back into the electronic health record, we need to deal with a little bit the idea that in at least some domains, the electronic health record is also a legal document that gets perused by lawyers that make sure that we've done our healthcare in the right way. So the idea of the My Research chart is that it's something that's not officially part of the legal health record, but it's a parking spot for research data that we want to put in and we want the clinicians to be able to see. So it's been widely used by the people that have been consented to use it. Right now we're in early days because it's a by consent process that you get access to My Research chart.
Thanks. I really think we need to push on this centralized versus decentralized, but I also really enjoyed the nuance from the panelists in that, like, let's think about the different layers we need to do. So one layer might be assembling a cohort of patients with rare diseases, so knowing enough that you can figure out where they are and find a way to engage them. Another might be broadly looking at the data for hypothesis generation, and a third might be the actual research you're doing with the clinical group. And the aspects of that might be centralized, other aspects decentralized. So while I think, I think it's a really important discussion, but also we should be very thoughtful about the different slices. My second my question for the group is a lot of efforts I've seen also rely on de-identified data being made available either completely publicly or to qualified researchers. And I'm curious to know, for the kinds of things you're looking at in eMERGE and others, to what extent de-identified data broadly accessible might be a layer of the stack in this centralized, decentralized piece. And then a final just note is Medicare enrollees have 3 years access to their coded data through Medicare Blue Button. If we could put that on steroids, it could actually really help with the Medicare data piece. But so the question is just thinking about decentralized, centralized as a stack, and also role of de-identified data.
So I think that was one of the reasons I wanted to make sure that we said that we weren't necessarily recommending a decentralized approach. My guess is that the right approach is a combination of the two. So if you can imagine a decentralized approach where everybody is collecting their data, curating it as it needed, but then feeding it, as we already do in eMERGE, to a centralized place where then it's now de-identified and can be queried appropriately. So you can imagine a lot of exciting opportunities to think about this resource that exists in the cloud somewhere that can be accessed, but where the data has been fed there by the local site. So I agree with you that we need to think about this as a set of layers, and that's exactly how we think about our de-identified data. So literally at our place, there's a single data warehouse that houses all this data, and then there's a view on top of it that's a de-identified view, and I suspect most places work exactly the same way. So again, it's that layer concept.
Yeah, I just wanted to add that, as was said before, that de-identified per HIPAA standards is not de-identified. We should all know that at this point. So it's always a risk, and it's a trade-off, the benefit and the risk. Therefore, given the patients, the control of that release is probably the right thing to do, rather than relying only on institutions that will be overly conservative for very good reasons, or on the de-identified concept, which if we put that de-identified data of our institutions out there, it's going to be re-identified. We know that. So given the patient a level of confidence of the cost benefit of doing this is the right thing to do.
And actually, to respect the clock, Sally Oaken gets the last question and or comment.
Oh, thank you so much. I wanted to share just a couple of thoughts of the work that we've been doing. You know, our data is very different than most of the data you'll find in EHRs. However, we code all of our data that's structured against the common terminologies and standard vocabulary. So everything is coded against ICD-10 and SNOMED and that sort of thing. So what we decided to do, because many of the end users of our data are going to be using it for different reasons, we, as I think Doug mentioned, talked about thinking about not a common data model, but where we map our data to common data models and then use the common data elements that make sense for that end user. So what we try to do is determine what's the end use of the data, and then think about how we can then have our data be useful and transformed in such a way that they can actually use it. So it's actually been quite successful, and it's just we're experimenting a lot with it with a lot of different end users. And then lastly, I would say that we also just recently ran an experiment with getting patient permission to get their records, and then using to triangulate that with them as well as with some claims data that we had access to through another partner. And we are actually able to show about 10% of the time that the data that the patients were looking at wasn't consistent with what they thought should be correct. So in terms of triangulating truths, it's also another opportunity for us to think about. And we've been experimenting in a couple of those ways, and I think that could be useful.
And the context for those of you who didn't recognize Sally's name, she was just talking about patients like me. Okay, so thank you for a very wide-ranging and vibrant discussion. Good answers, on point. So give yourselves a round of applause. And it's time for lunch, but I'm reminded that to ask that those of you who will be presenters in the after-lunch session, please bring up your slides or presentation materials now before you go to lunch. Thank you. And 5 after. 5 after the hour. I'm sorry. Last chance for cabs at the registration desk. To descend from the general to the specific.